welcome. My name is Peter Hudson. I'm the Director of the Centre for Palliative Care. Thank you very much for making time at the end of, I'm sure it's been a busy day for you to come along to this important presentation this afternoon. I'd like to formally acknowledge the traditional owners of this land, the Wurundjeri Nation, and pay respects to their elders and families. It's great to see a few colleagues and friends in the audience, but also several new faces. So for those of you who haven't come to one of these forums before, welcome. We usually have a few of these each year, so hopefully you'll be well rewarded by coming along today, and we hope you come back to another forum in the future. We have two guest speakers to present on this afternoon's topic today. However, unfortunately, Dr. Sonia Fullerton, due to personal circumstances, unforeseen circumstances, has been a late apology. But do not fret, you're in very good hands because we have Associate Professor Dr. Mark Boughey, who will be presenting on Sonia's behalf, and I'll introduce Mark more formally in due course. So we'll well cover off on some of the aspects that Sonia was going to portray this afternoon. Each of the speakers will have about 20 minutes to present, and then we'll have at least, I hope, 10 minutes at the very end for questions and comments. I will, however, we will greatly appreciate it, however, if we didn't focus on any matters related explicitly to euthanasia or assisted suicide. I mean, as I'm sure you all know, this matter is being debated in other forums, and there's other opportunities for that. We're not shying away from it. However, we don't want it to distract from the main content of this afternoon's presentation. So we appreciate your understanding of that for this afternoon's session. We will be filming the presentations this afternoon. That's just so we can make the presentations available more widely for those people that can't be here in person. But my understanding is, I think you're going to be okay because nobody's in front of the camera apart from our presenters. So I was going to actually offer you a chance to sort of not be on camera, but I don't think you are. When you are asking questions and so forth, I'll need to repeat the questions because our audio won't pick it up. So I don't think there's any particular way you would be identified if you were asking a question. But if you were concerned, perhaps do let us know when you're about to ask your question, and we'll make sure that you're not included in the final cut of the filmed version of this presentation. Also, too, importantly for these forums, we do allow a few minutes at the end to have a glass of wine or something to eat, and a chance just to meet old friends or indeed meet new people. So that networking opportunity is really important. So if you can grab a few minutes at the end of this, it'd be greatly appreciated. We're usually in one of the meeting rooms across the way. Our first speaker is Dr. John Chesterman. John is the Director of Strategy at the Office of the Public Advocate. He's a trained lawyer and was a lecturer at Melbourne University for almost 8 years in politics. He's the author of a number of books, one of which he co-authored on the politics of human rights in Australia. John is going to focus on some of the specific aspects of the new Act, and hopefully, as a consequence of his presentation, demystify some of the aspects of the new Act for us. Please make John feel welcome. Thank you.
Okay, thanks Peter, and thanks Karen for inviting me. It's a pleasure to be here, and it's nice to see some familiar faces and a friend in the audience. It's always good. And Ian, don't use the protection of anonymity to heckle me during my presentation, just because you won't be filmed. We can always turn the camera around. Look, I'd like to begin by acknowledging also the traditional owners of the land on which we meet, the Wurundjeri peoples of the Kulin Nation, and pay my respects to elders past and present. I also want to acknowledge the expertise that exists in the room. I'm aware when I'm delivering a presentation to an audience like this that there is a lot of expertise in the room, and I'm really actually looking forward to the questions later on when we get to hear about how some of the matters that I talk about now will actually be engaged in practice, and so your perspectives are going to be very important. I will keep to exactly to 20 minutes, And having been a lecturer, I'm reasonably good at doing that, so you can just yank me my neck if I'm going too long, but I won't. I'll keep right to 20 minutes. Firstly, very briefly, the Office of the Public Advocate is the adult guardian of last resort. You would know about us in that capacity. We conduct investigations for the Victorian Civil and Administrative Tribunal. We coordinate 4 volunteer programs. Very unusual for a statutory authority to have. We've got more than 800 volunteers. It's highly unusual. We provide some advocacy, individual and systemic, have an advice service and do some community education. That's who the Office of the Public Advocate is. We've also got some specific roles in relation to this legislation that I'm talking about, and I'll come to that in a minute, in addition to our role as adult guardian of last resort. Okay, so the Medical Treatment Planning and Decisions Act is what we're talking about. As Peter said, we are not talking about the voluntary assisted dying proposals that are still just proposals. They're not even in bill stage yet. They're not before Parliament. This is an act that comes into force on the 12th of March next year. If you like round numbers, kind of round, that's 222 days away until this act comes into force. It replaces almost all of the medical treatment provisions in the guardianship legislation and repeals the Medical Treatment Act of 1988. So it's a very key piece of legislation which in some gives patients greater say in the medical treatment decisions that affect them. It does this in 2 ways: by enabling people to create advanced care directives. It's really the first time we've had that in legislation, aside from our relatively obscure refusal of treatment certificate. It's the first time we've had advanced care directives able to be created by people according to legislative parameters. Also, we're moving away from the best interest model of substitute decision making in favour of what's called substitute judgment. So in short, that means if I'm making a decision for Karen and I have the authority to make that medical treatment decision, I'll be required to make that decision according to what I think Karen would have wanted, not according to what I think is best for her. So that's a big change. All right, so what will people be able to do from the 12th of March next year? We'll be able to complete binding instructional directives under which you can refuse medical treatment, including future treatment. So at present, with a refusal of treatment certificate, you can refuse treatment in relation to a current condition that you might have. This enables people to create binding instructional directives in relation to future treatment. Victorians will also be able to complete values directives. So values directives are ones that simply guide their medical treatment decision maker. So you'd all be aware that the moment we call the medical treatment decision maker usually the person responsible, the older language is next of kin. We're moving to new terminology, very descriptive, if wordy. Medical treatment decision maker is the new terminology. All right, the Act applies to all health practitioners and paramedics when providing medical treatment. So that's broader than currently is the case in relation to the Medical Treatment Act and the medical treatment provisions in the guardianship legislation. So there's a broader array of health practitioners who are covered by this legislation. We've also got a broader definition of medical treatment. Now, it's a much more, what you might call everyday definition of medical treatment that this legislation contains, which includes those dot points that I've got up there: treatment with physical or surgical therapy, treatment for mental illness, that's important, I'll come back to that in a second, treatment with prescription pharmaceuticals, dental treatment and palliative care. Now, treatment with prescription pharmaceuticals seems kind of obvious. It's an everyday definition of medical treatment. The guardianship legislation excludes pharmaceuticals and regular dosage levels from the definition of medical treatment. So, in short, what this means is that consent's going to be required for the provision of pharmaceuticals. If someone can't consent themselves, then substitute consent will need to be provided. That's currently not the case. You need compliance at the moment. You need someone willing to take the pill, but you don't actually need informed consent in the way that will be required. So that is a significant change. And that also has relevance for mental health treatment, most of which is in the form of pharmaceuticals. I'll come back to that in a second. All right, let's go on to just looking at how do you complete the advanced care directives. So an advanced care directive is a document in relation to medical treatment and applies in the event that the person doesn't have decision-making capacity for that treatment. So of course you can complete an advanced care directive, but if you've got the ability to make your own treatment decision, it doesn't come into play. It only comes into play if you don't. And there are two options there. You can set out binding instructions in an instructional directive or just preferences and values in a values directive. So as we say there, the instructional directive is an express statement of a person's medical treatment decision. It takes effect as if the person is consenting to or refusing that medical treatment. And a values directive is much more just a guide to the medical treatment decision maker. Example there, if I'm unable to recognise my family and friends and can't communicate, I don't want any medical treatment to prolong my life. It's up to the medical treatment decision maker for the values directive to interpret what that might mean and make a decision accordingly. Okay, so there are some requirements for creating an advanced care directive. It has to be in writing, in English, with certain requirements met there about signing and witnessing. Interestingly, point out one of the witnesses has to be a registered medical practitioner. When the legislation was originally drafted, the option was that you have to have two witnesses, one of whom could either be a medical practitioner or someone who could take affidavits, like a lawyer. But the second possibility was removed when the bill was in Parliament. And the reasons for that are not because a lawyer, for instance, couldn't assist someone to complete one of these and attest that they understood what they were doing. It's rather goes to how this thing might be implemented. So I'll give you an example. You might say, I never want to receive life support. You might put that in an instructional directive, and it might be signed with a lawyer, and the lawyer might say, well, you understand what this means? Yes, so it might be signed. However, when it comes to put it into practice, of course, a clinician, many people in the room might say, yes, but that might mean in 10 years' time you have surgery, and it might be reasonably typical following that surgery to be on life support for 25 minutes. This means you can't be. So I think that's part of the reason why it's just medical practitioners who are the authorised witness, so that kind of conversation can be had. Okay, I'll move on. When it comes to appointing a decision maker, the witnessing requirements are a bit more lenient. So one of the witnesses has to be either a medical practitioner or able to take affidavits, and there are requirements there. We used to, of course, until now, still do currently until the 12th of March, call these documents an enduring power of attorney. We've dropped that language and just called the appointment of medical treatment decision maker. Okay, so who are these people, the medical treatment decision maker? As I say, currently we call this person the person responsible. Previously the idea was the terminology was next of kin. It's interesting here, the Victorian Parliament has narrowed the list of people who are on this automatic statutory hierarchy. So you can see there they're limited to someone who's been appointed to the role, a guardian, and then the first of those people, a spouse, primary carer, adult child, parent, adult sibling. If more than one, the oldest of those persons. I've got identical twin daughters, one of whom is 1.5 minutes older than the other, so she would be higher than her sister. I do raise the argument with them that I consider them born at the same time, in the sense that they were conceived at exactly the same time. But anyway. Another point to note here, this is a new introduction, is there's a requirement that the person have a close and continuing relationship. So you can't be a kind of distant relation, fly in from Brisbane and suddenly have all this decision-making authority. So you have to have a close and continuing relationship. Where any questions arise about what does that mean, and if there's conflict, VCAT is the umpire, the Victorian Civil and Administrative Tribunal is the umpire for all of those questions that might arise. Okay, so when it comes to a medical treatment decision maker making a decision, as I said earlier, there's a change here. And the requirement is not that the medical treatment decision maker make a decision that they think is in the best interests of the person, but they're required to make the decision that they think the person would have made themselves. So they go through any expressed values that the person might have expressed in a written directive, or that can be inferred from the person's life. That may have been conversations, it may have been documents they've written, it may have been other things. But when making the decision, they're required, medical treatment decision maker is required to make the decision that they believe the person would have made. Failing that, they're required to make a decision that is consistent with the personal and social well-being of the individual, which is a new phrase and replaces that idea of best interests. We've put a note there down at the bottom, just special medical procedures such as procedures that would result in sterilisation or termination of a pregnancy and so on. They're still special medical procedures which require VCAT approval. And remember, we're all the time here, we're talking about people who, adults in this instance, who aren't able to make their own medical treatment decisions. When it comes to mental illness, so medical treatment includes treatment for mental illness and treatment with prescription pharmaceuticals, so said before. So that means that a person's medical treatment decision maker can consent to treatment for mental illness. That's a significant development. There are some arguments currently about whether that's possible now. I won't go into those kind of legal arguments, but certainly it will be the case that a medical treatment decision maker will be able to make mental health treatment decisions for a person. The compulsory provisions of the mental health legislation supersede any of this, override any of this. So if someone's a compulsory patient, then the Mental Health Act applies. But outside of people being compulsory patients, where a person whose mental illness doesn't enable them to be able to have capacity to make a treatment decision, then the medical treatment decision maker can have that role. That's a significant point. When it comes to ECT, however, the Mental Health Tribunal has to agree to ECT where a person can't consent to their own treatment, even if the medical treatment decision maker agrees with it. So ECT has to go to the Mental Health Tribunal for compulsory or indeed non-compulsory patients. Right, palliative care, of course, an area of interest. A health practitioner may administer palliative care to any person who doesn't have decision-making capacity for that care, despite any decision of the person's medical treatment decision maker. And importantly also, where someone puts in an instructional, a binding instructional directive, they don't want palliative care, that automatically gets read as a values directive, not as a binding instructional directive. There's a specific piece in the legislation that says that. So in other words, you can't refuse in an advanced care directive palliative care. Also important to note that medical practitioners will continue to assess whether a treatment's futile or non-beneficial and decide whether or not to offer it to a patient. That's an important point to make, and often when we're talking about end-of-life matters, there's a lot of confusion over what's kind of legally happening. Is a clinician deciding not to offer treatment, or is a person refusing treatment that's being offered? And so there are some technicalities around that which I'm happy to talk to during question time. All right, that's quite an important chart to look at in terms of what happens with the new medical treatment legislation. So we're talking about non-emergency situations. Bear in mind, in an emergency where it is apparent that the person has a binding instructional directive, then that needs to be honoured. However, there is no obligation on clinicians to search far and wide for an instructional directive. And of course, at the moment, there will be no registration of these forms. So short of a clinician being aware of it, either because the person's made them aware or a supportive advocate has made the clinician aware, how will a clinician know that this exists? That's a practice question that we're going to confront. Right, so outside of emergency situations, is there an instructional directive? If yes, we give effect to that instructional directive. If not, we go to the medical treatment decision maker for a decision. If the medical treatment decision maker is there and able to make a decision, they make the decision. If not, then we divide possible treatments into two categories: routine and significant. So routine treatment can be administered without consent, where there's no medical treatment decision maker. Significant treatment, however, where there's no medical treatment decision maker, has to come to the Office of the Public Advocate for approval for a decision, which might be approval, might be rejection of it. That's a change. At the moment we have what's called the Section 42K notice process, where there's no person responsible and treatment is being proposed, the person can't consent to it. Clinicians must lodge a Section 42K notice with the Office of the Public Advocate, which is a form of registration rather than strictly substitute consent. This will be a consent process, so OPA, the Public Advocate and her delegates will need to consent to that treatment for it to go ahead where it's significant treatment. What is significant treatment? Well, significant treatment is defined simply in these terms, and a lot is left up to further guidance that's being prepared as we speak. So the legislation talks about any of these dot points constituting significant treatment, where there's a significant degree of bodily intrusion, significant risk to the person, significant side effects, significant distress to the person. Now you'll note that's a mixture of objective and subjective elements. The objective elements are kind of the first three. The subjective one is the distress to the person. I'm calling the second dot point an objective one, a significant risk to the person. Of course, we're talking about the particular person though, but it's objective in the sense that others would agree on what the risk to that person would be, whereas significant distress is my feeling of distress. And I think about my family, some of us don't mind going to the dentist, some hate going to the dentist. That's probably not a bad example to talk about. Well, in some situations that would be significant treatment, in some situations it wouldn't be, on the basis of the distress caused to the person. There is guidance being prepared on this by the Department of Health and Human Services in collaboration with us and others, and working through a much more detailed flowchart about what constitutes significant treatment. Right, if a medical treatment decision maker refuses significant treatment, there is a new provision there whereby, and we're talking here about a small group of people whose preferences and values aren't known and aren't able to be known. So, for instance, a person with a lifelong significant cognitive impairment would fall into that category. Where a medical treatment decision maker is refusing significant treatment in that category, where the person's preferences aren't known or able to be known, then the Office of the Public Advocate has to be notified. One of the reasons for this is because we are broadening the power of people to be able to refuse all medical treatment by extending this to people on the automatic statutory hierarchy, to all medical treatment decision makers. There are reasons for that. We're getting rid of a bizarre and complex distinction we have in Victorian law that distinguishes withholding consent to treatment to refusing treatment. That's a distinction that very few people could explain, including lawyers, and very few lawyers could explain. But we're getting rid of that bizarre distinction and allowing medical treatment decision makers to refuse treatment, but there is that safeguard. All right, very quickly I'll talk about a new role in the legislation which is something of a nod to the emerging human rights concept of supported decision making that you'll be familiar with. And the legislation enables a person to appoint a support person. Now, what this does is enable a support person to get access, for instance, to information that health and privacy legislation would currently inhibit that person from having access to. But where you appoint a support person, so I appoint Karen as my support person, I'm still making the decision. Karen simply gets the legal authority to access information about me, which might help in her discussions with me about the kind of treatment I might want. And there are requirements around appointing a support person, which are very similar to the appointment of a medical treatment decision maker. I won't talk at any length about that, and these slides will be available. I'm just finishing up now. So there are some new roles for the Office of the Public Advocate on which I'll close. So we are the automatic decision maker in relation to significant treatment. Currently we register over 500 Section 42K notices a year. We're expecting this role to result in, we're not entirely sure how many decisions, but in the order of 1,000 in a year would be my estimate. We must be notified where medical treatment is refused by a medical treatment decision maker in relation to someone whose values and preferences are unable to be known. Our guardians will have expanded healthcare authority because there's a broader definition of medical treatment. That also applies to medical treatment decision makers. We'll have broader powers because the definition of medical treatment is broader, and we'll play a leading role around the education concerning the Act, and we are expecting a significant rise in demand for our advice service operators to answer queries, and we're more than happy to be providing that advice. So I'll stop right there. Thank you very much. Look forward to your questions later on.
Thanks very much, John. Our next speaker is Associate Professor Mark Boughey. Mark is the Director of Palliative Medicine at St Vincent's Hospital and Co-Deputy Director of the Centre for Palliative Care. He is also the state's chair of the Palliative Care Clinical Network. He sits on the executive committee of the Cancer Council's Clinical Network. He was Director of Palliative Medicine at Royal Melbourne for many years, and also Director of Palliative Medicine in the Northern Territory. Please make Mark feel welcome. He's going to talk to the clinical and practical application of the new Act, and in particular for palliative care. Thanks very much, Mark.
Thanks everybody, and again, it's good to see so many people in the audience this afternoon. I'm as interested today hearing about this as well. So I'm only sorry that Sonia's not here. As you know, if you know Sonia, her enthusiasm and passion often drags you along with the accompanying sort of gusto that she brings to her presentation. So I'm only sorry that she's not here to present on for herself. Great. Okay, thank you. I think what's important is that, again, it's even though the Act has come into play at the end of, or come into fruition at the end of December 2016, I think seems to have been a bit of a lag in the whole kind of knowledge about the implementation process, and I think this is a really good beginning of trying to understand the absolute clinical coalface impact of what will be, seemingly for a lot of healthcare practitioners, quite a radical change in the way they need to consider their decision-making and thoughts around the care and treatment that they're offering for patients, and certainly involving the medical decision makers, and also allowing for the new advocate to be involved in that, or support person in that process as well. John certainly covered some of the ground, so we'll be able to sort of move quickly, and it'll give us a bit more time for questions towards the end. So again, just covering some of the issues here, and I think the important one most probably is looking at the role of palliative care and advanced care planning. For many services, specialist palliative care, there's been some separation and siloing, I think, which we need to confront head on to see as part of our role as palliative care practitioners. If I was to say advanced care planning was easy, those of you in the room who are actively involved in this process, and it may be many of you, would most very blanch at that particular dictate. And of course, we all know that what we would hope to have in practice is the way this translates into practice. And from my point of view, obviously, the change in the Act and the new Act is to try and assist us to be better at being able to translate what is people's values and wishes that can then be translated onto a document, onto the forms, so that we can act in all good conscience in terms of values or in instruction at the time that we need to be involved in their care. Many of you all know these number of points that look at what is it that people look for when people is considering they're dying well, or they've had a good death, as people call. And I think what Sonia was trying to convey here particularly is that many of these, 4 of these, are actually covered by the Advanced Care Directive, Advanced Care Planning environment. And this is really particularly around feeling like they're being supported and involved in the care of the people around them, that they want involvement in and control over decisions that are being made, even if those decisions are being made after they've lost decision-making capacity. And they want the right services at the right time. And again, we often do see situations where the congruency of wishes for a patient aren't being met by the health services, or vice versa. We don't see that congruency. And again, we want to know the right people know the wishes sort of at the right time for the right care in the right place. So I think it's very important to consider these in translating again this into clinical practice. The new Act is specifically designed to assist not only the Office of Public Advocate but also clinicians in practice, and it is very difficult to take a new Act and sort of wade through it and decide which bits are relevant to me or not. And so I'm very grateful for the work that the department's been doing with the OPA to actually help in this process. Sonia wanted us to read the headlines, not the sort of headlines we'll be reading in News Corps or The Age, but these are the headlines around the Act. And certainly I think, as John has mentioned, is that it's taking a much more contemporary approach to decision making and how people make decisions and how they kind of live their lives and the decisions they make. And again, the instructional values. And as John's mentioned, not only considering the treatment decision maker but also the support person. Again, just to reiterate, and I think from a clinical perspective, that a sense that people can make decisions about future, and again the future medical conditions, that people can consent to treatments as well as refuse. So it's not always about reductionism, and it can be ones of trying to promote care as much as reducing and shaping so that you're refusing at the same time. And again, as mentioned before. And the important thing is the directives component, so the instructional directives certainly having statutory recognition, which does change the emphasis considerably in terms of sort of patients' directed patient rights in this particular arena. So I think, as has already been mentioned, and there has been a change in the hierarchy, so I won't go over this again, but really to say that the, I think she's got her acronym around the wrong way there, so treatment decision maker, I've just noticed. But anyway, really it's one about who's legally appointed, if not. So the legally appointed one would be the medical decision maker, but if not, then the guardian can be appointed through VCAT. And again, many of us in healthcare are familiar with the hierarchies. This is actually does simplify to some degree the hierarchy. I guess the complexity comes when you define what closeness and ongoing would mean. And does that mean somebody's got a sort of a Facebook, Skype relationship versus a physical relationship? And indeed, we have patients at the moment, I think, who have a very close relationship with their family member, but it's over the internet. It's not necessarily in the location of care. So this will be an interesting, I guess, challenge or debate that people may have at certain points in those, as the new legislation comes into practice in March next year. I think it's interesting, though, also that really the focus of what the medical decision maker can make is certainly around what is the best values or instructions of the person they're substituting for. And certainly it's trying to really carry that, I think, forward in the decisions that are being made with the clinical, medical, allied health, paramedics, all the people that are sort of defined under the APRA kind of banner of registered sort of healthcare practitioners in this sort of case. And that's often, I think, it's going to be a big shift for people, because often it's been it's been very much part of the medical culture to be thinking of these things, but it's a much broader cultural change to actually think about these things on behalf of all the other practitioners, particularly when they seem distant from maybe critical decision-making points. You know, people who are moving into, say, alternative therapies, or people moving into other areas like optometry and things like that. They often might seem quite distant, but there needs to be an awareness of these situations. Now, if I was standing here, I wouldn't want a pony, I can tell you that. I'd most very want to have some sort of therapy or treatment, and this is really just to indicate that you cannot, as is already mentioned, you can't be asking for something that is necessarily unlawful. And this is most probably in just commenting on assisted dying and the current legislation, obviously, that's before Parliament, or will be before Parliament, is that this is where assisted dying or any context around requesting assisted dying won't be able to be made. It's certainly been stated very clearly already that this won't be part of advanced care directives or advanced care planning into the future with the Victorian government. So again, that's very clear, and it's clear in the new legislation that's going forward, as mentioned just there. So I raised the question. We've now had clarification. I think when Sonia was developing these slides, it was before a couple of weeks ago when the recommendations had been made. So we've got certainly clarity around that now. I think the thing, and again this may come up in question time, in terms of compliance with instructional directives, is what does that mean? What does that mean to a clinician? And again, there are ability to act in good faith and all those sorts of parameters that we're already dealing with to some degree, but it hasn't been in a different sort of legal, I guess, framework to work from. And again, I think there is some time, there may be serious, and we may hear some questions on this. What does happen if there's not time to act or to contact or get things done through VCAT? What happens if this whole OPA process doesn't allow us to sort of make those sort of decisions in a timely sort of way? And particularly if the person who's the medical decision maker is potentially not acting in the, as we know, people's emotionalities come into play in many of these circumstances. So what happens if somebody is acting what they think is in the interest of the person, but actually it's more likely to be in the emotional response or the response of the family member or the colleague or whoever's been nominated as a medical decision maker. And again, the provisions around urgent and emergency care. And we may even, in the palliative care realm, as we know, we have a number of things that we classify as palliative care emergencies, and there may certainly be situations where those of us that work in specialist palliative care would certainly need to be mindful of this, that there may be opportunities where we can act in this area as well. So for those of you who do work in specialist palliative care or palliative care in general, really just to focus, Sonia wanted us just to focus a little bit on palliative care and its relationship to the new Act, because as I said before, there's sometimes been a bit of a separation, and certainly palliative care shouldn't necessarily be holding advanced care planning and advanced care directives. As you know, most institutions and services will have an advanced care planning, advanced care directives program. There will also be end-of-life care programs. There'll be palliative care programs. Some of them are all linked, others work under the same framework, but really advanced care planning should be part of every person's healthcare journey, and I guess earlier the better if there's particularly difficult diagnoses or there's progressive serious illness and so forth. There should be, the flags and triggers should already be in place for when these discussions should be occurring. So again, because it sits under the values environment, palliative care can't be refused. And again, as we know, at the coalface, that's often sometimes a negotiated process of treatment for, say, pain that's refused by the family and the patient, and then working our way through the sort of communication skills process, which can take sometimes a few days to move through to actually be able to allocate good pain management as part of a palliative care plan. So again, these aren't always, I'm focusing on the more difficult environments, but this is where we're challenged in some of these new arenas. Of course, anyone working in palliative care needs to be aware of these situations, of not only the values, but also the directional, instructional aspects of their care as well. And I think really, if necessary, we need to certainly be conscious of a consultation with the decision maker, or again, if there isn't, those that fit into the hierarchy of close and proximal to the patient. We've mentioned this already a couple of times, and I suppose it's useful for us to know that that's part of the equation as well, which is terrific. What's important most probably, and Sonia wanted to highlight this, was that reasonable efforts, again, is a loose definition, I guess, but really it's to try and give a sense that, that there is protections in some way to healthcare professionals, clinicians in this, that there are at times when Sometimes we need to be not almost second guessing, but we need to try and be working in that framework. And we need to be working in the framework of recognising where the patient is in their trajectory and illness and what's actually available or not available. So it's very easy to say, well, I want cardiopulmonary resuscitation, but if circumstances have changed so significantly that you wouldn't offer cardiopulmonary resuscitation to a person who's actively dying, then there needs to be sort of reasonable efforts to take into account this, I think, in that process. So that's certainly some discussion may need to be going on at that time. I think it's important, though this is important, we all know how when people present to hospital particularly, how our medical staff, juniors, senior particularly, a little bit more remote from it all, how difficult it is to get us to be part of the equation of asking things on first request. If you look at the completion rate of not for resuscitation, goals of care, forms and so forth when people come into hospital, even though it's asked of patients or it's asked that it be completed on each presentation, it's still a very difficult process in the active process of determining what's going on for a patient and family member and trying to work out the healthcare needs. And so I think it's important to recognise that the asking seems a simple task. How that translates into practice will be interesting to see. But really, hopefully the onus will start to increase. Certainly I've seen a big change at St V's in the way that we're starting to ask the questions. Is there a medical power of attorney, injury medical power of attorney? Is there an advanced care plan, etc., etc.? So those questions are certainly coming up. And I think this just solidifies that in the process as well. But there is an onus to actually, for healthcare professionals to ask. And it's going to become really critical if we don't ask, particularly in the transferring between community and hospitals, paramedic environment, general practice environment, particularly any environment that I guess patients are moving around the system in. It's going to be critical that people have access and understand if there is an advanced care sort of planning process in place. Again, capacity, decision-making capacity is something that we often all struggle with, and our interpretation can be different and sometimes not the conclusion that the family would like us to come to. So again, the issues around decision-making capacity of a patient so that the then medical decision-maker can become the primary person to be involved in that decision-making process, and where that tussle. So again, we sometimes see those extremes where somebody's quite cognitively impaired, maybe it's dementia, but the family have a sort of a denial cone of silence over their family, and they won't accept that this person's got cognitive impairment. And so how do you then sort of work through those sorts of processes as well? But again, it comes down to the whole notion of reasonable efforts in this process to find and to enact a medical treatment decision maker. Again, I think John's mentioned this as well, is that really, we're not there to affect our duty of care and to try and focus on what's best care. It's really giving context to the care that a patient wants for their care, and that reasonable circumstances are being made to find out whether there is an advanced directive or a decision maker. If you're not able to, and reasonable efforts have been made, however that's sort of defined or considered, then it's not necessarily seen as unprofessional conduct. And again, provisions in giving urgent care, emergency care, which is seen as a reasonable thing. Maybe there's a context you'd be doing this normally for patients, is that there needs to be recorded in writing that, if you didn't think the person had decision-making capacity, but why you've given the treatment or why you've gone ahead and done this at this particular time. And again, just similarly with routine, again, it's been mentioned already, there's both the significant treatment and the routine treatment type of environment. How are we doing? A couple of minutes? Okay. I just better see where Sonia's pace has got me to at this moment. Not too far from the end. Okay, I think she's... okay. And again, I think we're just again, focusing on very similar stuff that John has mentioned as well. What I think is important, though, existing medical power of attorney and refusal of treatment certificates are still valid. So even though there's a changing environment, that these are still valid, I understand, unless others have got other information to this extent. If I had a little bit more time, we'd most probably focus on just one small case, but you could most probably read on this that if somebody comes with maybe there's a problem of dehydration and confusion and constipation in the cancer setting, often, and this is somebody who comes to a palliative care sort of environment, because they come to emergency, they're seen as somebody that most probably isn't necessarily they've got all the things in place, but I guess the question that people, Sonia wanted us to understand is that there's an instructional directive, but the family are sort of demanding or asking for investigation of hypercalcemia. And so the thoughts around this, I guess, would be, we could do this in the question time if you like, but it's really thinking through, has the person got decision-making capacity or not, even though they might have some confusion. If they have got decision-making capacity, then it really is ultimately up to the patient themselves, and you may have to include an interpreter in this setting, depending on whether there's capacity to understand things in English or not. And then really, I guess if the routine treatment has been to investigate and treat previous hypercalcemia, then it may be seen as another episode of that particular treatment. But if it's if it's an initial problem, then it may seem as much more a significant treatment, that this is something that needs to be investigated and treated. So it's an interesting, and certainly in his instructional directives, there's no actual specific thing saying I do not want hypercalcemia treated. Although, and then you'd have to argue around whether something's life-prolonging or not. Now, ultimately, with hypercalcemia untreated, it's not a life, to treat it would be a life-prolonging episode. So again, it brings in that question of would you initiate the treatment or not. So again, it brings up a lot to talk about and work through with families. And as we know, this is very much focused on a communication task. It's not just reading a form and saying, look what your dad said. It's kind of, you have to step the family through the process of what the implications of having a high calcium might be, and why, if you were wanted to reflect their wishes or his wishes, that you would be most probably not looking at initiating that treatment at this stage in this particular illness. Or you might think it's the first presentation and you might think that this needs to be. So you may have to context the discussions in a different frame depending on where it is in that disease or illness trajectory. Interesting. Okay. So I think just summing up a little bit, I think you need to consider any valid and relevant values directive. Consider the preferences a person has expressed. I think you're most probably aware, I think John sort of touched on it, you can have both a values and instructional directive, but the instructional directive is very much I use the word gazump. Does it gazump? Is that the word? But obviously there's the basis to it, but the legal framework certainly supports the instructional directive rather than kind of focusing just on the values directive. Okay. Just quickly to finish off, often it's difficult to find where the advanced care planning is happening and where the advanced care plans are. And so I think part of the future, and when this hits the road, is it's again really amplifying what people are already doing in terms of the advanced care planning environment. The ability to have a single documents and so forth translated electronically across the system, access and so forth. How do we look at the focusing on review and renewal of these, particularly instructional directives? How do we, as you may know, that people under the age of 18 can't do a values directive, it has to be instructional. And so what happens if somebody moves in that transition but hasn't an opportunity to change? Because there are certainly some very savvy young adults that have a lot of values and value-driven. So there's some issues around the whole young adult interface, teen to adult interface. But also, I think, just generally, it's a bit like how often people in the room who have wills, how often do you review them? Is there a check date? You know, do you check your fire alarms and your will on the same date or something like that? Do you check your advance directive just in case they all sort of tie together? But there most really needs to be some triggers to allow for proper review as people's healthcare conditions change. And so this will be certainly a new territory for all of us in many ways. What's interesting, I think, is there is most probably a need for palliative care to be involved, and that this is just to give some sense in the last year of life. Again, like wills, many people can come towards the last days, hours of life and still haven't completed any sort of will documentation around wills. Similarly, I think there'll be a certain percentage of people where advanced care planning directives may never be part of their equation, even though it's continually offered. But for the majority of people, we need to make sure that these sorts of things are coming into play in place a long time before we're predicting sort of the last year of life type of trajectory. And I'm sure in your end-of-life care committees and advanced care planning committees around hospitals and health services, people have talked about this quite a bit. How do we get this in place? I think really that we need to make sure that there is the connection between palliative care and advanced care planning. If advanced care plans aren't in place and people still have decision-making capacity, we should still, at referral time, be involved in encouraging that process to occur, if not actively going through that process. So just to summarise, and sorry to be a few minutes late, we need to remember that the advanced care plan directive process is really about trying to capture something that we have all, in the past we've assumed that some people know that knowledge, but we're trying to capture, we're capturing it on a form, and we know about the limitations of forms, but we're trying to capture the sort of context. We're trying to capture somebody who can advocate and speak on their behalf, but we can also capture a medical decision maker who can actually make those concrete decisions on their behalf. We all have a role, and I think this is, to me, is the big challenge. We have trouble enough skilling our medical and advanced practice people in good communication skills around these things. I'm just wondering how we are going to roll out good communication and good communication skills around other healthcare professionals across the board to be able to operationalise and make sense of these documents in that process at the same time. And I think we all anticipate a dawning of this new process in March next year. I'm still waiting to see the official implementation process take light. So it seems like a very short time frame before the official rollout is supposedly occurring. So if anyone's seen anything that I haven't seen, I'd be grateful to hear about it. So thank you.
Thanks, Mark. On behalf of us all, we do appreciate you stepping in at the last minute, and thank you very much. So questions, please, and if you wouldn't mind, if you're able, if it's a clinical question, perhaps you could direct it to Mark, and if it's not, then to John. And if you're not sure, we'll work it out up here. So please ask away.
Yeah. Okay. Yeah.
Hi, I'm Tanya from the Southern Metropolitan Region Palliative Care Consortium. This is a question for John. Actually, two questions, but one was really fast. Can you appoint more than one medical treatment decision maker?
So
No.
I'll the question is, could there be appointing more than one medical treatment decision maker?
Just one.
Oh,
Just one.
sorry.
And the other question is, if the medical treatment decision maker does something that a clinician would think is, not in the, or not according to the values of the patient, what happens to the medical treatment decision maker?
So the question is, if a medical treatment decision maker makes a decision which seems to be not congruent with the actual person's values or instructional directives, what's the consequences to that person?
Yes, well, if it's an instructional directive, the medical treatment decision maker doesn't have a role. But if it's just the belief that the decision is being made not according to the values and preferences of the person, then an application can be made to VCAT to remove that person from that role. Also bear in mind in that scenario we are talking about situations where particular treatment is being offered that's being often refused in that situation. So we have to be clear about, is the treatment actually being offered?
Bernadette.
Sorry, I've got a question up here.
Oh, okay. Sorry, Bernadette.
Thanks. It's for John, and it's Mike Kennedy from Palliative Care Victoria. One of the questions that we got asked when we were talking with called communities was how this might work in practice, given that it's got to be in English and signed for, say, a Greek older woman who doesn't speak English. How, in a practical sense, is that going to happen and not be open to challenge about whether or not she understood what it was that she signed?
So the question is, if you've got somebody of a non-English speaking background, you mentioned a Greek family, if they are asked to do this and then there's a sort of challenge in the environment afterwards with the medical decision maker about what's been discussed or not.
Yes, it's a good question, a good practical question in relation to jurisdiction like Victoria. We have so many people from court backgrounds. In short, what you need to do is ensure, if we're talking about an instructional directive, an independent interpreter would need to be explaining what happens and then sign the form also saying that they believe this is a true expression of what the person has articulated. That's the best way to ensure that it would remain valid. Using a family member, for instance, is more likely going to raise questions about the validity of the instructional directive, but it's a good question.
And I think these aren't new struggles either. I think clinically we already struggle in this environment with the whole translation, a document that's in English but trying to translate it through the whole realm of different languages, and particularly when decision making is not always an individual response, it's a collective family, community response to a particular question. So it'll be interesting, I think.
My question's about the witnessing from the medical practitioner, and you explained about why the person able to take affidavits was dropped off. The Act seems relatively silent to me on the amount of information that is expected for the medical practitioner to have provided as part of guiding the decision-making process. And that then becomes relevant if you're trying subsequently to interpret it, especially if you're trying to decide if you would use that section of the Act which allows you to not follow an instructional directive because you believe that the person's views or wishes may have changed. I'm from an acute care background, and that particular element becomes very troubling for us because obviously if you choose to be guided by a directive which is poorly informed, you could be withholding treatment that actually the person would want to have.
So again, the questions around the signing by a medical practitioner and the amount of information and knowledge that can be conveyed in that sort of transaction and discussion in terms of actually informing, I guess, a person who wants to make a directive with the right information for the right issues and problems.
Yeah, look, it's a really good question, it's a good observation, and we've identified this as well, that whilst I gave those reasons for people who can take affidavits being dropped off the authorised list, there's in fact no extra obligation on the authorised witness, in this case for instructional directive, the medical practitioner, on having special duties and roles in relation to explaining. What they're required to do is simply attest to the fact that the person understands what it is that they're signing and the implications of it. There's no requirement, for instance, for them to spell out all the situations where this might apply and the person might not realise it might apply. There's no specific obligation there. It's more a kind of a hope, I think, that the drafters of the legislation may have had. But it's a good observation. One of the reasons why there is a requirement for a high level of having an authorised witness is in the past where we've had authorised witnesses for things like enduring powers of attorney, where that could be, for instance, a justice of the peace. There have been situations where they are simply signing the document to say, I've seen this person sign the document, not that the person's understood the document, which of course is technically what's been required.
I think clinically as well, it's a tricky environment. If I think about how the oncology environment is changing so rapidly over the last 5 to 10 years, and So you do see times when people say, I don't want any chemotherapy, even at get-go from their treatment. But what people don't realise is that every cancer has a different trajectory, different treatment regime, and in fact chemotherapy for many is no longer the first treatment in that armament. And so there's all this, so such great change. So it would be interesting to see how those sorts of scenarios, and I guess that's where some of the moving away from the instructional directive may occur, when people see best care, best treatment having to be enacted to treat a particular malignancy or something.
Yes, and just following on from that, we think the values directives are going to be far more heavily utilised than the instructional directive, and indeed in the creation of the forms around these documents, it's going to be very important to make sure that people are aware exactly what they're signing up to, because bear in mind these things could be valid 20, 30 years hence.
You just have to read the book Amsterdam. I don't know if anyone's read not Amsterdam. Yeah, is it Amsterdam? Amsterdam by Ian McEwan, to see what happens 20 or 30 years after somebody's made some verbal instructional directive. So.
I was just wondering if you can comment on the reasoning behind not registering the documents, because it just seems to be such an ongoing issue that people never produce the documents.
I'll just repeat, so the question is about no requirement for registration, and why is that? Everyone who talks about registration of these instruments agrees with registration. So no one will give you a reason for not doing it other than it hasn't been done or required yet. So of course My Health Record is the obvious place where this would go one day, and failing that, how are you supposed to know, how is a clinician supposed to know that someone has a directive short of the person themselves, or an advocate / supporter / medical treatment decision-maker drawing it to their attention? Well, they can't. So until registration is compulsory, we can't have that kind of certainty around A, requiring a database to be checked, and B, ensuring that where there is a document it's given due regard.
Certainly in my work around end-of-life care plans, sort of around the globe, it's the same situation. Smaller jurisdictions, often single-state countries, etc. It's much more an easy thing to orchestrate and organise. It just seems, in our particular situation, it's difficult to orchestrate a single registry of these sorts of documents.
You will be able to upload voluntarily to My Health Record, but that's a voluntary one. Until it's compulsory, there's no kind of requirement to check the database.
I'm sorry, everyone, we do need to bring the session to a close. We have run out of time. Thank you very much to the Centre for Palliative Care staff, in particular Nikki, and there's been others behind the scenes who have done all the hard work in preparing things for today. So thank you very much, everybody at the Centre for Palliative Care. And if I can draw your attention to, I think you've got a couple of documents in your handouts, hopefully one of which is an evaluation form. We do appreciate any comments that you might have about today's forum, and in particular any ideas that you may have for future forums. We want these sessions to be topical, to be contemporary matters that we need to discuss as a community in caring for people with advanced disease. And also to let you know about the National Palliative Care Research Colloquium, which is the 26th and 27th of October. I think you've got a flyer about that as well. If not, it's on the Centre for Palliative Care website. But that's an opportunity, if you're interested in evidence-based practice in the care of people with advanced disease, then please come along to that colloquium later in the year. And finally, just to thank our two speakers. Thank you very much, John, for an excellent presentation there in a very short period of time. And thank you again, Mark, for stepping in for Sonia at the last minute. It's a very difficult task, so we appreciate it greatly.